Well, I think the ERN is a tremendous step forward, and I believe it's going to change things, particularly in the countries of the eastern half of the community, where frankly the sarcoma care is less sophisticated, there's less expertise generally, and the healthcare structures are not as robust as they are in the West.
I completely agree. One of the things that have been demonstrated in recent years in the experience of several countries, including UK, including Scandinavian countries and several others, is that the management of this patient is best done when in reference centers. And the problem is that not all countries have identified reference centers. And sometimes countries have not been able to identify the reference centers because it's not organized this way. So this is probably where ERN can help.
As you know, we have taken on with Sarcoma Patients Euronet a worldwide remit now, and we really do want to see other countries as well stepping up and treating sarcoma patients the way we want to be treated and the way we are generally being treated in Western Europe.
Yes, and I think that's a very important point, to be able to disseminate this expertise that has been acquired for years, decades sometimes, in some European countries, because they invested in this question of how to take care of patients with rare cancers. And actually a lot of requests came from non-European countries saying, how can we jump in this network? In 2018, we are probably a bit immature to start this, but at least we would all like to start the first connection to help them. It's quite clear that the level of evidence in rare tumors is by definition lower in rare cancers because you have less trials. The understanding of the disease and actually the optimal diagnosis is not that optimal, unfortunately, for a large proportion of patients. So for all these reasons, the quality of the evidence is lower. But the good news is that we also have the opportunity to have very well-defined, narrow, nosological entities, type of diseases, which are, in a sense, much better characterized than in frequent tumors. So because of that, we can decide to treat GIST with D842V mutation. We know how to do it. Imagine for a frequent tumor how it could be. They would be lost in the stream.
The evidence base is 50 patients in the world.
That's right.
It's intriguing how many good studies now, really good studies, of the regulatory process, which have looked at how quality of life has failed to figure in the assessment, even though it was there in the protocol for the RCT, which was the foundation of the regulatory approval. And there's certainly some evidence that quality of life has just not been handled properly in clinical trials.
Yeah, I think you're absolutely right. We have probably not very good tools, and we seldom use them to all patients. I mean, some patients are escaping from this evaluation. It's not a primary endpoint, and it's complicated to fill up 2 or 3 pages every 2 weeks or 6 weeks or whatever. So that's something which we should change. And I very much believe, by the way, that the new technologies such as portable devices which can inform on a daily basis quality of life will help us a lot in this direction.
Well, of course, that as an issue raises the whole matter of big data and the fact that we need an investment in technology and in systems to allow us to gather, store and analyze the data. And the data that can be produced will help everyone. It will help regulators, it will help clinicians, it will help patients. One of the things that came up in the roundtable from Paulo de Tos was the issue of histology, understanding the morphology, and needing to be able to do it better. Now, in this world of genetics, is that so important, really?
I really believe it's going to be very important still in the immediate and long-term future, I must say. Because at the end of the day, if you think about it, histology, what all these pathologists have been able to achieve in the last 50 years is a resulting phenomenon from all the genetics of these tumors. So it's an integration of what is happening. So genetics refines and tells you a lot of things. But it's not going to be enough, and it will never replace morphology. So you will need to have a morphology standpoint, which is going to be the integration of everything. We'll still need pathologists, but the pathologist is going to need biology, molecular biology, and probably even artificial intelligence to help them.
Can our pathology networks in Europe deliver that so that the clinicians can make the most appropriate decisions? I worry about that.
Yes, I think it's worrisome always to be able to maintain the networks which are existing. I think you are right. We need also to maintain a group of expert pathologists of a sufficient number to be able to cope with, because we are getting organized, so we are going to have more and more secondary reviews of the histologies. So they are going to have much more work than they used to have. So we need to expand this group. And pathology, I think, is a medical discipline of the future in this perspective.
I believe that we are not seeing the best of research in sarcoma yet. And I think the reason for that is that we are still trying too many old models of basically testing an experimental treatment against a known tumour, without actually looking back at ourselves and saying, are we asking the right questions?
Probably with the experience growing as we progress in our career, I really believe that we have not been asking enough simple questions, very simple questions, straightforward. And of course, we are in a world of sophistication. Molecular biology comes in, and we are very keen to understand what we do not know, and that's understandable. But still, very simple things such as how do we ensure that the patients are being treated in the right center? How do we organize that? How can we make research to check that this is ongoing and this is impacting patient life? How can we use the tools that we have in the simplest way? Well, we have to simplify the question. In a sense, the work on rare tumors is feeding a lot the work on frequent tumors. Some very large databases on rare cancers, including sarcoma, are larger than large databases of frequent cancers.
Well, that's down to the diligence of you and your colleagues, and I would suggest also a little bit of pressure from the patient.
Absolutely. It's really a collaborative work, and this is one thing I like very much in the field of rare cancer, is that we are so well connected. We know each other, it's easy to work together.